Hi everyone, today we are going to study about the receptor binding. In receptor binding, there have been two types of stimulus, agonist and antagonist. The agonist will give full effect after attaching with the receptor, and antagonist will inhibit or stop the effect of the reaction after attacking with the receptor. And you already know there are two types of inhibitors, competitive and non-competitive. The competitive are knocked out by increasing the concentration of a substrate, but the non-competitive did not be moved by increasing the concentration of substance. If you make it easy, the non-competitive and competitive inhibitors destroy the receptors or decrease the number of receptors for the drug. So if the receptors, the number of receptors will be decreased, then effect of drug will also decrease. It will be fine for you, but we will start from the competitive inhibitor. For example, this is the first graph, and this graph is about the agonist dose. First, we are giving an agonist of a drug. It will be increasing the maximum effect and giving a maximum effect after the injecting. But if you are giving agonist with the competitive antagonist, okay, we are giving agonist with competitive antagonist, then what will be happen? I already told you guys the competitive inhibitors will be removed. First will be happen when you keep the antagonist, the effect of that drug will be stopped. But for overcome that inhibiting effect of inhibitors or antagonists, we will increase the concentration of agonist. When the concentration of agonist will be increases, the competitive inhibitor will be knocked out, and you will again go the same effect as the agonist was giving, but this was on the dose. But before giving the antagonist, on 5 grams we are getting the maximum effect. But after giving the competitive antagonist, we are getting the same effect on 10 grams. So if you recall about the previous topic about the efficacy and potency, if we're getting a desired effect in very minimum, less amount of drug, then it is called potency. So after giving the competitive inhibitors, competitive antagonists, the potency of drug will be changed. But competitive antagonists did not change the efficacy. Efficacy is the maximum effect of a drug that can be produced. If you notice on the graph, before with only agonists we're getting this effect 100%. After the agonist and competitive antagonists we're getting same effect. But the dose is changed only, but we are getting the maximum effect. So with the competitive agonist, the efficacy will not change, but potency will be decreased. And you already know that it can be overcome by increased agonist concentration. With the competitive inhibitors can be knocked out by increasing the concentration of substrate. And we have in the example like Pharma is the agonist. And we are the flumazenil, the competitive antagonist on the GABA receptors. Same this phenomena will be happen. If we are giving the flumazenil and we are not getting the maximum effect, then we really increase the concentration of diazepam and we will get our maximum effect if we want. Okay? Now we are moving to the next topic, that's a non-competitive antagonist. Non-competitive antagonist, I already told you, it means stating in simple words, it means we are destroying the receptors but decreasing the number of receptors. Non-competitive antagonist means they are blocking the receptor permanently, meaning they are destroying the receptor, decreasing the number of receptors in the body. So, let's see the graph, this one. The second graph, first we injected the agonist and we are getting our desired effect. The potency is okay and efficacy is also fine. But after giving the agonist with the non-competitive antagonist, the effect will be in decrease. The effect will be decreased. But if you guys can check, we are getting 80-50 effective effect, like desired effect on the same dose, but its maximum effect is getting less because when we are giving only an agonist, for example, when we will be injecting this drug, the number of receptors was 100. But after giving non-competitive antagonist, receptor will decrease to 60 or 50. So, now we are giving antagonist or drug. The drug will act only on these receptors and we are getting the effect only from these receptors, then the effect will be decreased. So in the simple meanings, the potency will be not changed in non-competitive antagonists. The efficacy will be decreased. Efficacy means the maximum effect a drug can produce. And if you check here, the maximum effect is decreasing. So efficacy will be decreased or reduced. And already you guys know the non-competitive inhibitor can't be overcome by increased concentration of agonist. Also having the example norepinephrine, that's an agonist. With then non-competitive antagonist at the phenoxybenzamine on the receptors. Fine. And third, we have in the example of partial agonist. What is a partial agonist? The partial agonist means they will not act properly like agonist, but it will give 50% of effect like agonist. Okay. A new theme, we're having one more graph here. Above the partial agonist, for example, it's at 0 dose. When you are giving the agonist, the desired effect is increasing, you're getting the efficacy and potency. But after giving the partial agonist, you are giving the partial agonist with the agonist, as the effect is increasing. I will make one more graph for you guys. For example, this is a graph. This is a concentration of agonist, and this is a concentration of partial agonist. When the concentration of agonist for the high, the effect for the maximum. Okay, for example, it is effect. But as we are increasing the concentration of partial agonist, at this point, agonist was high, effect was also high. But as we are increasing the concentration of partial agonist, the desired effect will be decreasing. The desired effect will be decreasing. And the main point in there is that agonist will be completely replaced by partial agonist. And when the partial agonist replaces all the agonist, then effect will be decreases. And secondly, the partial agonist will be attached on the same or active site, where agonist will be attached on the receptor. I think it will be clear for you guys. So the partial agonist is the independent for the potency, but it will decrease the efficacy. It will decrease efficacy because we already know after giving the agonist with the partial agonist, it will be indicated. So you can say that if you are giving agonist and partial agonist together, then partial agonists act like antagonists. It will be very simple for you. If you are giving agonist with partial agonist, it will attack the antagonist. It will decrease in the efficacy. But if you are giving partial agonist with antagonist, then it will be increased on effect. Or maybe it will be actor anchor agonist. Understand? But it acts at the same time as the full agonist. And secondly, as I already know, if you are giving agonist and partial agonist in the same time, then partial agonist can replace all the agonist molecules because they are also attaching on the same site of the receptor. Like morphine is a full agonist, and the buprenorphine is a partial agonist at the opioid receptors. Mostly the student patient having the of chronic treatment or long treatment by the opioids. So we are giving the both opioids and full agonist and the partial agonist to decrease the side effects of the opioids. I told you that in worse agonist, the potency and efficacy of the independent can be decreased or increased, but it binds to the consistently active receptor, thereby reducing its activity, has the opposite effect of the agonist. And by attaching inverse agonist, the inverse agonist system will, like inverse mean opposite, so it will act like an antagonist. And like H-anti-estra means like diphenhydra means this all. So what about the receptor binding? And the receptor binding, we already know we having the competitive antagonist and non-competitive antibody and competitive antagonist. The potency of the drug will be increased. If we are giving non-competitive antagonist with the agonist, then efficacy will be decreased. And thirdly, we also having some receptors like spare receptors. The spare receptors activate when others receptor will be blocked. It's a very interesting thing, guys. And very interesting and a high real thing, and many times the people and students are confused. Like some systems having a spare receptor, like I am blocking alpha-1. When I am giving the alpha-1 blockers, or the receptor will be blocked, but there are some spare receptors that will act as alpha-1. And you will think I am giving alpha-1 blocker, but I am getting effect of alpha-1. Which receptors are given? There is some spare receptor. The maximum response can occur even setting on blockade receptors. If you are blocking any receptors, then these spare receptors will become active and they will give their own effect and you will be confused. I am giving blockers, but again I am getting the effect phi. Experiment T spare receptor demonstrated by using irreversible antagonists. It prevents the binding of agonists to the portion of receptors, and high concentration of agonists still produce maximum effect. For example, I will make one graph. If I make the graph for you guys, this is the one graph in which I am putting 3 scenarios. This is the first scenario. I am giving only agonist, and I am getting the maximum effect. Second scenario, I am given the agonist with low dose of non-competitive antagonist. What I am getting? Maximum effect. But if I gave agonist, if I gave agonist with high dose, non-competitive antagonist that I am getting, less effect of efficacy will be decreased. The thing is that the spare receptor will be act when you are given the low dose of non-competitive antagonist. But for overcome the spare receptors or overcome the effect of spare receptors in some systems, you have to give high dose of non-competitive antagonist. Now I want to discuss a little bit about partial agonism because I have in some examples like minizapindolone, acipitolone. These was all antihypertensive drugs we was using in past times. They activate the beta receptor, but to less degree. Like less strictly to non-epinephrine. If you know the non-epinephrine is the agonist equilibrium maximum effect. But the pindolone or acipitolone activate the beta receptor, but it activate to the less degree. And it also activate the entrancing symptomatic activity of sympathetic system. But it having a side effect that is very important for the exam, USMLE exam, that pindolone we are not using now that due to its side effect of angina. Because this drug can cause the angina through vasoconstriction. And second, I have an example of buprenorphine. Ready? Yeah. Give example here. It mostly used for the treatment for the opioid dependence. Already I told you guys. For the treatment of opioid dependence, we're using this drug because it's the partial agonist of opioid receptors. Entire day's example of clomiphene. The clomiphene is the partial agonist of estrogen receptors. And the estrogen receptor in the hypothalamus, and it blocks the negative feedback and increases the level of LH FSH. And it is mostly used for the infertility and in the PCOS, polycystic ovarian syndrome. It is all about the receptor binding and receptor binding. They are competitive antagonists, non-competitive antagonist, and partial antagonist. Now we are going to study about the therapeutic index. The therapeutic index is a measurement of drug safety and is having two values, the first is the toxic dose and second having the effective dose. The meeting toxic dose and effective toxic dose. The ratio of toxic dose and effective dose keep the therapeutic index. The therapeutic window means our range that is safe for the patient to treat the disease, and the range of a drug concentration it can be safely and effectively treat disease. It is for example, is the 5 gram and this is the 100 gram. From 5 gram to the 100 gram, it is a range. If I give to the patient paracetamol from for example, 5 gram to 100 gram, it will be safe for the patient. But if I am giving more than 100 grams, about 105 grams to the patient, it will give a toxic effect and it will show some symptoms about the side effects of the drug. And this means it will be called therapeutic window. We having a mnemonic to the tide. The tide mnemonic is used for the formula of therapeutic index, like TI for the therapeutic index, and TE variation. That's the toxic dose divided by the effective dose. Like say for drugs having the high therapeutic index, like one drug having a very weak therapeutic window, like 1 gram to 1,000 grams. And it is a very high therapeutic index value. Then these drugs are more safer than other drugs, which having a window of 1 gram to 5 gram, 1 gram to 3 gram, like very narrow windows. Okay? The drugs having higher therapeutic index values are the safer drugs. Drugs with a lower therapeutic values require monitoring due to their side effects. And these drugs include warfarin, theophylline, digoxin, anti-epileptic drugs. And lithium, and we having a mnemonic that warning. It is a dangerous sign. These drugs are lithium. W stand for warfarin, T stand for theophylline, D stand for digoxin, and E stand for anti-epileptic, and L stand for lithium. Like lithium dose, lithium medium dose often places the toxic zone in animal study. For example, if a Researcher is studying about the drug response. Then, instead of writing toxic dose, he will use thermofluid dose. The 10 dose mean death dose in the animals. Before it was a study, this output about the therapeutic index. Therapeutic index, mainly the measurement of a drug about its dose, how much it will be safe for the patient. And already you guys know one the mnemonic tide that about the formula of therapeutic index. Therapeutic index is equal to the ratio of toxic dose divided by effective dose. Fine. Let's talk about the graph given in therapeutic index. On x-axis we have the drug concentration, and on y-axis we have the response of patient. On this point we are injecting the drug, and on this point, for example, it was 0 grams, 5 gram, 10 gram, 15 gram, and 20 gram. On 10 gram we are getting over desired effect. The point we are getting the desired effect is the value of effective dose. Effective dose value is 10 gram. Okay? And if you notice, we are increasing the dose with the time, and at that dose, at 20 gram, we are getting the symptoms and sign of side effects or toxic dose. So we will note this value at the medium toxic dose, that is 20 gram. If we divide more, then you get 2 gram. Okay? We get the 2 gram as therapeutic index. Understand? This is all about this graph. Again, I am saying the therapeutic index is the ratio of dose divided by effective dose. Now we are going to start about our topic, that is drug effect modification, like how one drug can be changed the effect of another drug if we give them together, if we administer both drugs together. Okay, now we will going to study these effects. It's a definite effect: additive, permissive, synergistic, potentiation, antagonist, and tachyphylaxis. First, we will talk about the additive effect. Additive effect seems like 1 plus 1 is equals to 2. If you are giving 2 tablets, 2 drugs together, if it give it the body effect, and if both drugs act together, it will be beneficial for the patient. Same, the effective substance like drug A and a B together is equal to the sum of the individual effect. It will give a mod effect, like equal. For if you guys know, if 2 person are fighting for one thing, then if you're more good than 1 person asking, okay? It seems like that drug 1 and drug 2 give an effect of AB, like A plus B plus AB. That's simple. We have in the example of aspirin and acetaminophen, Dynol. If you guys know that both drugs are inhibitors of what? Cyclooxygenase. Oxygenase mean it disrupts the pathway of arachidonic acid, and we mostly give for the painkiller both drugs together. Second is permissive. Permissive means the presence of substance A required for the full effect of substance B. Like for example, when partner is this, and it is the husband, and he's saying, if my wife will come, then I will do that work. And this effect is called permissive. Like one person need the permission of another one to do that work. Same is happening for the drugs. We're having one example of cortisol or catecholamine. What will happen on cortisol? It's just like a cloud. Okay? First, we will do a simple effect of cortisol. What the cortisol is doing? The cortisol upregulate the receptors on the arterioles. The receptors are alpha-1 receptors. The cortisol degrade the alpha-1 receptors. And these receptors cultivate the concentration of smooth muscles with the help of catecholamines. Okay? When cortisol regulate alpha-1 receptor, after upregulation, the catecholamines come and act on alpha-1 receptors. Understand? So, let's make an example for you guys. For example, the cortisol is just like a cloud that is raining. When it start raining, the flowers, that is the alpha-1 receptor. After getting the water and the number of flowers getting increasing and they are exposing themselves, they are opening and exposing their tail to the honeybees. And honeybees are non-epinephrines, and catecholamines. When honeybee go and it will make honey openly, so as much flowers expose themselves to honeybees, the effect will be increase or you get the maximum effect. Same like that, the cortisol will come, upregulate the alpha-1 receptors. When alpha-1 receptor exposed itself for the catecholamines, then catecholamines will come, adapt and give it maximum effect. And this effect is permissive. The effect is permissive effect. Understand? Our third effect is synergistic effect. Synergistic effect is a substance A and B together and integrated in a sum of their indirect effects. It's the one proverb, the 1 plus 1 can be equal to 11. Mean to say A plus B is equal to ABC. For example, when two drugs combine, they will give the maximum effect on additional effect. A maximum effect with some additional effects. Same is happening with the synergistic. It will give when the water will administer together, it will give a greater effect. For example, perpendicular with the aspirin. This I am not talking I will not talk about the mechanism, but I will say too, indeed, more drug we will give deficient for the inhibition of platelets aggregation to prevent the formation of thrombus, and it is given for the prevention of stroke. When we give both drugs together, then it will give a maximum effect on it. Effect and additional effect also. It will give maximum plus additional effect also. Fine? And the next effect is a potentiation. The potentiation is a little bit similar to synergism, but drug B with no therapeutic action enhance the therapeutic action. Drug A. For example, we are given drug A, but the additional drug, the drug B, will enhance its effects only. The drug B having no work, having no effect at all, but it is only enhancing the effect of drug A. For example, carbidopa equals to block the enzyme to prevent the peripheral conversion of levodopa. Because you are taking levodopa, but when you are taking alone, like levodopa, if you are administering levodopa alone, then it will be converted by the peripheral enzymes, and its effect will be decreased. Okay, you did not get the effect of levodopa for the maximum time. The time of effect will be decreased, but when you combine the levodopa with the carbidopa will protect the levodopa from the conversion, and it will without the maximum effect for the maximum time. And this is called potentiation. And now we are talking about antagonistic effect. You all guys know antagonistic mean opposite is only inverse. For example, you are taking one drug A, and if you're getting some effects of this drug, adverse effect or toxic effect, to eliminate these effects, you are taking a B drug to decrease that adverse effects. And we have in the example of morphine with the naloxone. Morphine the opioid, and naloxone is the antidote of that. Fine? Daily tachyphylaxis. Tachy means rapid, and phylactic means protection. Acute decrease in response to a drug after initial repeated administration. It means when you are taking a drug chronic and repeatedly you are using the same drug if you're given some side effects or some response to your drug. For that, we will use some tachyphylaxis drugs like therapeutic intermittent decongestants like oxymetazoline. It would decrease a therapeutic response with decrease the rebound congestion, because when you are using these, it will decrease the number of blockers. The decrease on number of receptors that will upregulate the effect. And for the next time, what will happen? Like when you was taking an intranasal decongestant, the drug dose was within 5 grams. But when you will use next time, for the desired effect, for getting the desired effect, you need 10 grams. If you're using again, now for getting the desired, you have to use 15 grams. So it is a little bit like that when you are given that you decrease in the response of drug after the initiation and repeated administration. Like if you are using a drug repeatedly again and again, the response will be decreased. Okay? That's all about the drug effect modification in these. Let me tell in comment section which effect you like most. Which one is interesting? Like additive, permissive, is synergistic. If you have a girlfriend and girlfriend is opine you, then you relate to permissive because the permissions is a very good feed when somebody taking permission from yourself, okay? Again, I will summarize. I want to summarize the additive effect. The additive effect. It's a sum of effect of two drugs. Permissive, one drug need to help with another to give it maximum effect. Synergistic, maximum effect plus additional effect. Potentiation mean one drug supporting other drug to work, like carbidopa supporting levodopa, antagonistic inhibition that you effect, and tachyphylaxis effect. An effect that is decreasing due to the repetition of doses that the patient is using or repetition of administration decrease the effect of the drug. And for that, we have to increase the dose to get the desired effect.